Welcome back to the Growth Paramedic channel. This is your host Marvin, and on the next Clinical Talks episode, we're going to be talking about cognitive overload, the clinician killer. And it's a topic I'm quite excited to go through because I think it is very relevant to the world that we work in, and of the fact that we as pre-hospital providers are seeing very unwell patients, often for the first time, and have to make a lot of critical and time-sensitive decisions within a resource-limited environment. And so cognitive overload can very well be a common occurrence, and it's important as clinicians to be aware of our own limitations and our own weaknesses, and in order to make better outcomes, be aware of this dangerous problem evolving when we do treat patients who are unwell. So what is cognitive overload? Well, cognitive overload is defined when the resources needed to make a decision exceeds that of the available resources at hand. Really simply put, is when we are thinking of too many things at one time. Our mind is a very simple, and it can be complex, system of thoughts and processes. And when we are in a very stressful environment, if we are trying to juggle or multitask potentially important things like patient assessment, history taking, airway management, medications, if we try to do that all as one person, it's very easy to fall into the trap of becoming overloaded and making a bad mistake that can lead to a poor outcome. There are three sources of load, which is part of what's known as the cognitive load theory. And these are the things that essentially make up our cognitive load, our thinking, our thought process. We need to be aware that cognitive processing is a constant flux of information, an ongoing act of making sense of the information of the environment around us, of things that we take in, and learning from it, and making a decision or making an opinion from that information. Now, firstly, intrinsic cognitive load, which is the first part of the three, refers to the level of cognitive effort you need to expend to complete a problem or a task. That's generally the main thing that we are doing anytime we are talking to a patient. We're trying to find out, is this patient sick? Do we need to go to hospital? What other things do I need to do to make or complete the problem at hand, which is figuring out what is the provisional diagnosis of this patient. Then we've got our extrinsic load. And extrinsic is basically the cognitive effort that's demanded by the working environment around us. So rather than it being within us, it's often information that's placed upon us from outside factors. And when we are bombarded with information that often we cannot control. And so, for example, if you were in a pre-hospital environment with an unwell patient, and this patient, let's just say, was presenting with stroke, who is fast positive, you would recognize you need to go to hospital fairly quickly to get it scanned and to get them fixed and get them into an operating room. The problem you could get, which is classed as extrinsic, is you may get information from your partner that the elevator is broken down, or you can't actually get this patient out right now because there's 3 flights of stairs and you're going to need to get back up like rescue to get them out. And suddenly now you got this extrinsic load you need to think about because you are stuck now where you are, and you now need to think, what can I do now to manage this patient? I know this patient needs to go somewhere, but this information that I can't control has forced me to stay in this area, and I know this patient is going to get worse. So now I need to start thinking about other factors. Now, germane cognitive load is the effort expended to make sense of new information. This is a very common one we will experience when we have critically unwell patients. So when I mean by new information, it's things like a sudden change in patient condition. They go into cardiac arrest. They become really short of breath. You find that the alarm on your monitors is flashing and their SpO2 that was initially 99% is going down to 80%. That is new information. You need to start making sense of that. Like, what's going on to cause a change in their condition? And you need to use your knowledge of pathophysiology. You need to know the baseline of the patient's observations when you got there, or you need to have some idea of the presentation to try and make sense of that information. So you can imagine if everything came together and it was a perfect storm. Let's just say you had your intrinsic. So let's use our stroke patient, for example. You're trying to work out this patient is having a stroke. They're presenting with fast positive signs. Your partner just told you that you're going to be stuck there for another 30 minutes with an actively stroking out patient. And now you find the patient's becoming unconscious with you and their rest rate's going down. The heart rate's going bradycardic. You now have a patient that's crashing. So you've got all of the three sources of load suddenly pushing onto you, and that's going to cause potentially cognitive overload. And in those cases, that is when bad things can happen if we don't have plans in place to try and reduce that. Now, with cognitive overload, when does it begin to manifest? I guess an easy way to consider if you're on a job, is this about to result in cognitive overload, is the moment you are doing more than one task. We generally are terrible at multitasking. There's an often common phrase, you can be the jack of all trades, but a master of none. It falls very well with the cognitive overload principle, is that when you're trying to do one thing, especially if it's a critically unwell patient, if you're trying to do one thing, if you're trying to do multiple things at a time, you won't do them very well. And some examples I will have is, let's just say you're the treating officer. If you decide to do the history taking, and you also decide to attempt to do a vital signs whilst asking questions, and then you halfway through all that decide, I'm going to give you a medication. Let's talk about a chest pain, for example. You're doing a history taking, the patient's clutching their chest. You decide to ask them about the history taking. Whilst you're doing that, you're putting on the blood pressure, you're putting on a 12 lead, but your mind's thinking, what questions do I need to ask? I need to ask the PQRST pain acronym, right? I need to also hear what the feedback is from the patient, but I also need to think about, what about the 12 lead placements? You know, V4, V1, where is that? Well, that's mid-anterior, right? Or is that left lateral? Oh, and then suddenly I need to make sure that I don't miss the Crocroft sounds of the blood pressure cuff, or what is that SpO2 doing? And then I'm thinking, well, actually, this patient's got chest pain, right? I'm looking back at my protocols. This patient is going to need to have aspirin, or is going to need to have something else. But I've missed the part that the patient's saying the pain is radiating from the chest to the back, and this could be aortic aneurysm. You can see how very quickly trying to do multiple things at once, you can't do it well, which is why I always say it's really important to delegate tasks. And that's a principle I'm going to mention in a couple more slides down the track. When you're doing history taking, you need to be engaged in the history taking. You need to ask the question, listen to what they say, and then explore the answer that they give you using bridging questions. You don't ask questions to tick a box. You ask questions to build a picture of the patient presentation. In the same way, a vital signs survey. If you're going to get a vital signs survey, it needs to be a full vital signs survey, because it may only take one abnormal vital sign to guide you down a track that will lead you to your provisional diagnosis. An example could be a BGL. If you don't do a BGL and you find the patient's BGL is rating high, well, you could very well have missed the fact that the patient's hyperglycemic and potentially in a DKA. The same thing with your medications. If you decide to I'll just quickly give you aspirin, you may have missed the fact that you didn't go through your 5 rights of medications. You didn't ask if the patient had any allergies, they've ever had it before. You didn't think about the adverse effects. Like example, giving glycerol trinitrate for a chest pain. Do you have IV access? Are you prepared for the patient to have a sudden reaction to the GTN, to have drop in blood pressure and potentially have a syncope if they're standing or if they're sitting up? Where are you? Are you prepared for them to fall on you? Do you want them on the stretcher in the ambulance, or are you happy to do it on scene where you're up 2 flights of stairs? These are the things you need to be thinking about every time you decide to do one task. You try to do them all at once, recipe for disaster. Key point about this whole talk is that cognitive overload does kill patients. You can get bad outcomes from trying to rush processes in a critical unwell patient. And even the best clinician only has one brain. There's no two brains we have. Yes, we have a left hemisphere and a right hemisphere, but they're all connected. We are humans after all. We are not robots. And as much as we like to use ChatGPT, when we are processing information, require full attention and full concentration for maximal output. And completing tasks are made worse if it's not linked together. And when it's not linked together, it's a recipe for disaster. And what I mean by that is doing one task and doing something that's completely opposite to the task you're doing. An example of when you're doing two tasks that are similar is if you're managing the airway and breathing. That's all in the same anatomy, you're in the same position. It's a lot less cognitive overload compared to if you are on the airway and you're trying to delegate, or you're trying to say, let's give midazolam 5 milligrams, and you're trying to go through medications for another condition or another problem that you have. If you are, for example, on one task like the airway, you are the airway. That means you're not looking at circulation, you're not looking at extrication, you are monitoring that ventilation, you are monitoring that oxygenation, you are looking at all the vital signs that relate to oxygenation. That is your goal, and that is how you reduce cognitive overload, by delegating tasks and sticking to certain tasks where the resources allow you to. Now, always remember is that your ABCs should always have their own clinicians managing it. Remember, when we do our primary survey, our ABCs are the first things we address, because if we don't manage our ABCs, that is what's going to kill a patient. So airway, breathing, circulation. There should ideally be a clinician on the airway, and they can also take on the breathing. But if you remember, in some really unwell patients, one patient or one clinician will be on the airway maintaining head tilt and jaw thrust, or holding on to the adjuncts, airway adjuncts, and you have another clinician helping ventilate or to monitor the oxygenation of that patient. So one's purely focused on maintaining that patent airway, and the other one may be ventilating. If you have a higher skilled or higher ranked clinician, they may be more than fine to manage that ABC, which again are very similar tasks in the same area, which is not as cognitively overloaded. Now, for example, circulation, medications. So if you have someone who's focused on IV access, they should just be focused on IV access, focused on looking at the anatomy of the arms, the legs, looking at what medications they need to give, what the dosage is, the 5 routes of medications. Actually, these days, I believe it's the 6 routes of medications. And then you have another clinician doing documentation, another clinician doing scene management. This is more to do on your very unwell patients where you're going to have multiple crews on scene. Try to spread the load that is cognitive overload to everyone. And so there's less stress on one individual person to perform. Key things to be mindful of when cognitive overload occurs is that when you do have a situation where you are either in cognitive overload, or you believe a clinician on scene is cognitively overloaded, is that it can either delay or result in incorrect decision making. There can be missed or overlooked information, and there's always a risk of implementing a bias, like an anchoring bias, especially when we're trying to reduce that overload in our heads. Protocol deviations, that's always a risky one when we're trying to rush things, and you may not fully understand in that moment where the guidelines that you are endorsed to do fall under, and you may accidentally, without proper awareness, go outside of your scope. That's always a very dangerous one that cognitive overload can result in. So always be mindful of protocol deviations when you're overloaded. Communication breakdown. I will always say this: a scene is a bad scene if it is quiet. That means that everyone's brains on scene, they're overloaded. There's tunnel vision, there's stress. things will be missed in a quiet scene, because if no one's saying something, something is bound to happen and no one's going to say anything and pick it up. So you should always be using communication, closed loop communication, using names, identifying roles, what everyone's doing, what's our plan. Increase burnout, increase stress. If you're cognitive overloaded, chances are you're going to be having those experiences multiple times in your careers, maybe multiple times in a shift, and heck, multiple times in a set block of rosters. And so it's very easy when your head's always flushed in the overloaded state, you're going to feel very burnt out and stressed on your days off or before even going to work, because you're expecting to experience that again and again and again. Compromise safety. When we are overloaded, we can compromise safety. We can try and get things done quicker without following the appropriate safe processes in place. And when is it most likely going to occur? Well, I simplify it down to 4 times where cognitive overload is most likely to be present. And that's your big jobs. Big jobs, multi-vehicle collisions, mass casualty jobs. So anything that has multiple patients, limited resources, a high stress environment. Complex jobs, jobs where extrication is a nightmare, or you need to do a whole bunch of things in order to get the patient out from that area. Because now you need to not only think about maintaining and stabilizing the patient, but work on how can I safely get this patient out of this difficult situation. So think about a cliff face, think about a tunnel, think about a bushland, work sites. And then you have your sick jobs, your critically unwell patients. So those patients who are peri-arrest, those patients who have known pathology that's going to result in a bad outcome, and there's really nothing you can do right now except get them out. So your triple A's, your strokes, your STEMIs, your traumas, blunt traumas with internal bleeding. And then, of course, you have your routine jobs that suddenly become your sick or complex jobs. They can be the most overloaded because you are dealing with all those new germane cognitive loads, new information. Common one, nursing home. You go to what you think is a normal transfer of a patient. You get there, the patient's peri-arrest. What's going on? What's happened? This is not what the information has told me. I now need to make sense of what's going on. I need to figure out, do I have enough backup? What do I need to do? Is this patient for resuscitation? Or am I going to have to do something right now to keep them alive? Huge, huge time where cognitive overload can happen. So this is how I try to break down or try to make cognitive overload a little bit easier. And I call it the IPDR process, which is simply identify, prioritize, delegate, and review. These 4 components, if you apply them anytime you think you're about to be cognitively overloaded or you have a situation that's going to cause cognitive overload, apply these 4 steps. So identify. You need to identify that you're cognitively overloaded, or you're in a space that will result in cognitive overload. You can't begin to fix something if you don't know you're in that place. And that does require some self-critical thinking, some self-reflection, which is why you're watching or listening to this session. You now have the ability to identify potential places, potential things that can cause cognitive overload. And by identifying, you now are in the first steps to managing that cognitive overload. The next one, prioritize. What are the things that need to be completed? And often you need to prioritize in a way that what are the things that need to be done first, that if you don't do, will kill the patient. So you need to make sure that the order of care is done from the most important to the least important. And that requires communication with your teammates and working with your teammates. So for example, you have an unconscious patient, your priorities is to manage that airway, get a full vital sign, get a history taking, and then extricate. You're not going to move the patient. You're going to get them into the ambulance. If they're already unconscious on the floor, you're going to start managing them on scene. That is prioritizing your goals of care. And then we lead into our next part, which is kind of in the same time frame as prioritizing, is delegating roles. You have a partner. In most cases, there's going to be other people around in that scene. There's going to be someone who potentially has more knowledge in a certain area that you have, or has less knowledge. Like you might be an intensive care paramedic, or you might be a qualified paramedic, or you might be a trainee paramedic. So when you're delegating roles, you want to make sure that the person who's most skilled or competent in doing that role is assigned to that skill, or someone who is most competent in doing that skill is assigned to that role. So if you have a patient with a difficult airway, you want to make sure that the person, often your ICP, is on the airway managing that problem. You can get your trainee, if they're comfortable, making sure they get a documentation of what's happening, or you can ensure that the team dynamic is identified early on before you even get to scene. So you can say, I'm going to do this, I'm going to do that. Can I get you to do this? Can I get you to do that? So if you're going to someone, or your MDT says that you're going to cardiac arrest, you can already, before you get to scene, identify that this is going to be a lot of cognitive overload. Let's delegate roles now. I know what skill set I have. I know what my partner's comfortable with. Let's establish our roles. Let's delegate our roles before we even get to scene. So look, use this as early as you can, because it does help in the long run. I've used this, helped me in many occasions. And so when we then have a delegation of roles and we know what everyone's doing to the level that they're capable of, we then want to always review patient care. And reviewing can be done at any point, but essentially reviewing is involving pause points, thinking outside the box, or thinking about the bigger picture, and being aware of analysis paralysis, using or implementation of any potential biases, and communication. And so when we are, let's just say, halfway through, or we're 10 minutes into a job, well, let's review what we have done so far. Let's use a pause point. Let's see how everyone's tracking, because chances are we are already at a cognitive overloaded state. Let's quickly de-escalate that. Let's get back to a nice flow state. And then in another 10 minutes, or if you notice something isn't right, let's go back and review by identifying, prioritizing, delegating. Review, go back, identify, prioritize, delegate. And that is one of the easiest ways that I have found to make a team dynamic work very well in our critically unwell patients. And if you look at all of that, a lot of it is communication, being able to talk to your colleagues and be able to talk to patients and bystanders on scene helps a lot with most of these principles that I've mentioned. And I mentioned about pause points. I will have this in its own clinical talks, but really simply a pause point, or they call it a medical pause point, is an intentional communication to the team about discussing the patient's situation. Pause points are there often to stop negative momentum. And what I mean by negative momentum, when we have a critically unwell patient, and a lot of times cognitive overload is with our critical unwell patients. So just let's stick with the unwell patient, because if they're very well or it's routine, we're not really going to be seeing our cognitive overload. But when we have a critically unwell patient, there is a chance that due to the stress and due to the overloaded nature of these jobs, we go into what's known as negative momentum. And so negative momentum is a situation in patient care where, by one reason or another, the clinicians on scene have missed something, whether it's through analysis paralysis, tunnel vision, biased, missing some key clues or key findings. But going down that route and not identifying it will result in worsening state of patient, and then eventually a bad outcome. And pause points are designed to help alleviate, or at least attempt to resolve, any situation where a negative momentum is building. And an example of that I can give in the pre-hospital context is, you have a patient who's gone to cardiac arrest, you've done a shock you've got a ROSC or return of spontaneous circulation. You've told, or at least the person on the airway or someone in the field has said, let's just get this patient onto our stretcher. Let's just get going. We've got a pulse. Let's keep moving. That is the time to initiate a pause point. Your patient has arrested. We've got ROSC. That is a time where these patients can re-arrest the easiest. So you need to say in those cases, let's do a pause point, guys. What do we have? Or at least what do we know? What do we have? What do we need? Ideally, this is initiated by the most senior clinician because that helps show leadership in those cases, but anyone can say this. And it's a way to identify that you want things done without directly before you need to go to that point of saying, stop, we need to do this. Because in those places or in those contexts, people are already tense. So pause points opens up constructive communication. And in this case here, pause point, let's look at what we need and what we have. For example, this patient's in cardiac arrest. We got ROSC. Do we have monitoring gear on? Do we have a 12 lead? Do we have bilateral IV access? Do we have fluids running if we need it? Do we have adrenaline drawn? Do we have an airway plan? Do we have... we need to start talking about all those things that we need in place to ensure that if something was to go wrong, we can start to fix it. And it allows everyone to talk in a safe environment. By having a pause point implemented, and I love using pause points in critical moments where we need to change or make decisions. It allows clinicians to input their findings into a pool of clinical discussion and ensures that everyone's on the same boat. Because chances are, but at that point, everyone's been thinking things in their head, or they've made their own through their understanding of the patient's presentation. They've made their own conclusions on what things have been done and what things haven't. And so by ensuring that everyone's on board about what things have actually been done, you can then pick up, well, hang on, do we have an IV line in? And the patient or your partner can say, yes, we got an IV line in. Has that line been flushed? No, I didn't get a chance to. Can we just quickly flush that line to confirm it? They do the flush. Oh, I'm actually getting pushback. I'm not getting any flush. I don't think this line's patent. Well, there we have it. We actually don't have a line that's patent. If this patient was going to cardiac arrest and you had that line that wasn't patent and you only found it out after the fact, you now have a bad outcome potentially. And so then you can think, okay, let's get rid of that line. Let's go for another one on the right hand. We may need to start thinking about IO. You can very quickly see how pause points can be helpful in stopping a negative momentum from building. And that's why I love using them. There's no real criteria when you need to implement them. It's just a toolbox, or it's a tool you can add to your toolbox. Now, let's face the facts. I will always say this, we will experience cognitive overload. You can't avoid it. It's just the way that our work is. We will see patients often and potentially for the first time within a healthcare professional environment. We will be bombarded with information that we have to make sense of. We will have situations that are outside of our control that we need to mitigate, to resolve, to address, to manage. And so it's not a matter of if, but it's more of a matter of when. But we can implement things to mitigate the effects. And the first one is always use a checklist when they are available. If you're doing a cardiac arrest, have your cardiac arrest checklist if you have one. Have it opened, have it available on the scene where everyone can pick it up if they need to. Keep your protocols and guidelines easy to reach for direct reference. This isn't a game of how well you can memorize things, because I can tell you right now, when you are stressed, it is very hard to remember every contraindication for every drug that you can use. So reference your medications, have your guidelines there. Train often. Train in high stress scenarios that allow you to test your cognitive capabilities within a high stress load. And the best way to do that is using simulations. So maybe going onto a course where they use real actors or live patients to simulate what could be your next big job. Of course, using crew resource management techniques, your CRM, for better team dynamics. And communication is always one of those bigger things that I just can't emphasize enough. You need to be able to talk to your colleagues. You need to be able to build constructive progress in patient care. Debrief always after what could be a cognitively overloaded case. Never let that simmer in the background. Try and break down what happened at that job, what things went well. Use whatever debrief tools that you guys use in your services. But if it was a job where a lot of things happened and you identified in your 4 steps that this was very much a case that would have high cognitive overload, you want to discuss ways that things happened, what went well, and what can you do the next time you go to that job. Because the more you build upon your experiences, the less likely you're going to be cognitively overloaded when you go to the same job again. Anyway, that ends it for this session. If you guys enjoyed it, make sure to comment, let me know your thoughts, and if you have any other questions, you know how to contact me.